Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, Professor of Interventional Radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
Okay, let's unpack this. We are diving into acute porto-mesenteric venous thrombosis, or PVT, and focusing specifically on non-cirrhotic patients. For those of you who work in interventional settings, this is a condition that, well, it really demands our immediate attention. While the estimated prevalence is relatively low, around 3.7 per 100,000, it's critical because about half of all acute PVT cases actually occur in individuals without underlying cirrhosis. That makes it a key primary differential for us.
And the gravity of the situation, acute PVT is a potentially life-threatening event. If you have complete obstruction, it doesn't just impact hepatic function. It can rapidly progress to severe bowel compromise. And if that thrombosis extends into the splenic and superior mesenteric veins, the 30-day mortality rate is, well, it's alarmingly high. We're talking up to 32%.
32%. That really sets the stakes. So for the IR trainee or attending learning alongside us, our mission today is to move past the just medical management. Because while systemic anticoagulation is the first line of defense, the evidence for interventional treatment is evolving fast. We need a deep dive into the spectrum of endovascular techniques, the growing data supporting devices like new large-bore thrombectomy systems, and most critically, the clinical decision points where we pivot from medical therapy to life-saving intervention. Especially in these newer, really complex presentations like COVID-19-associated coagulopathy and vaccine-induced thrombotic thrombocytopenia, VITT, right?
And before we even touch on techniques, we have to talk about language. In a situation this complex, standardized terminology is paramount. We rely on the Bovino 7th consensus, and this is just key for consistency. We categorize PVT as recent if it's less than 6 months old versus, chronic if it's been around longer than that.
And the degree of occlusion that dictates our aggressiveness, right?
Yeah, absolutely. We need to describe whether the vessel is completely occluded, partially occluded, so greater than 50% clot, or minimally occluded, which is less than 50%.
Right.
And of course, the ultimate severe chronic sequela we are all trying to prevent is cavernous transformation. These precise descriptors are what allow us to compare outcomes across different institutions.
Okay, so let's start with the fundamental problem. Why does this happen? We always frame the etiology within the Virchow triad, the interplay of stasis, endothelial damage, and hypercoagulability.
And what becomes apparent really quickly when working up these non-cirrhotic patients is the underlying complexity. We're not often dealing with a single cause. Data shows that up to 52% of these patients have a general, often inherited prothrombotic disorder, and up to 36% have both local and general risk factors happening at the same time.
That's a massive takeaway for anyone focused on the workup. If you only look for local factors, you're missing the underlying systemic driver in half your patients. You have to be exhaustive in that hypercoagulability screen.
Precisely. The IR team needs to recognize which high-yield etiologies demand follow-up. Myeloproliferative disorders are present in 21% of patients. The prothrombin G202010A gene mutation is found in 14%, but you can't ignore the local triggers either. Abdominal inflammation is a huge contributor, present in 34% of cases overall. And acute pancreatitis alone, that's implicated in a really wide range, something like 23% to 57%. It often leads to a transient PVT that can quickly become permanent.
And spontaneous recanalization is rare. We're talking about 16.7%. So systemic anticoagulation is clearly the standard first-line treatment, typically for at least 3 to 6 months.
But that's where the evidence really shows us the limitations of medical management alone. You start anticoagulation, and after 6 months, you only see about 50% achieving complete recanalization, and only 40% achieving partial. That 10% failure rate for any recanalization, plus the 50% who still have residual clot, that just demands an interventional strategy.
So why is that recanalization rate stuck at 50%? Is the underlying hypercoagulable state just too aggressive for anticoagulation alone?
That's exactly the challenge. The clot burden in the acute setting can just be so large and the resistance to slow so high that systemic anticoagulation really struggles to overcome the sheer mechanical obstruction and that persistent inflammatory state. Which brings us to the threshold for intervention. We generally consider medical therapy to have failed when there's refractory persistent thrombosis after 6 months, or, and this is the critical part, when the patient presents with escalating severe mesenteric ischemia that requires immediate escalation to clear the clot.
Right. And when anticoagulation fails, our goals in the non-cirrhotic patient are aggressive and they're clear. Rapid thrombus removal and reestablishing portal outflow. The point isn't just to survive the acute event, but to prevent the permanent chronic sequelae, chiefly that cavernous transformation.
And this is where we start talking about catheter-directed thrombolysis, or CDT, sort of the traditional chemical debulking strategy.
CDT, right? It involves localized fibrinolytic delivery, usually via a transjugular or a direct percutaneous approach. And it's a key point for all trainees. Transarterial thrombolysis via the SMA is largely non-recommended now. The risk of GI bleeding is just too high, reported up to 28%. We have safer options.
But when you use it appropriately, often combined with mechanical clot removal, the efficacy data for CDT is really compelling. Meta-analyses show high success rates. We're talking around 84% recanalization and 86% symptom improvement, so significantly better than anticoagulation alone.
But the bleeding risk is always the major concern, right? It hovers around 7% for major adverse events, almost all of which are hemorrhagic, and that inherent bleeding risk is precisely why mechanical thrombectomy, or MT, has evolved so rapidly.
Well, the theoretical benefit of leading with MT is speed and safety. You aggressively debulk that large clot burden first, which minimizes the necessary duration of CDT, and that, lowers that hemorrhagic risk. And the data actually supports this hybrid approach. MT combined with CDT achieved a mean CDT duration of just 22.7 hours compared to 44 hours for thrombolysis alone. Cutting the thrombolytic infusion time in half is a safety advantage.
And we've seen a rapid technological leap here. We're moving away from older fragmentation techniques, and we're using these large-bore thrombectomy devices, angiojet, trellis, penumbra, the ecosystem. We're seeing excellent results, like that study reporting 100% technical success in thrombectomy for TIPS.
That's excellent immediate technical success, for sure, but the critical question for long-term practice is rethrombosis. What are the one-year patency rates?
That's the real challenge, isn't it? The risk of rethrombosis is definitely present. Sometimes it's attributed to mechanical venous wall damage or endothelial damage caused by the thrombectomy devices themselves, or maybe just the persistence of the underlying prothrombotic condition, which highlights why clot removal alone is insufficient. It constantly emphasizes the need for a robust outflow strategy, and that means integrating TIPS.
TIPS is the crucial physiological component. Residual intrahepatic thrombus, or even just simple outflow resistance from the underlying disease, can provoke immediate rethrombosis. TIPS provides that necessary decompression by bypassing the high resistance. And we're also increasingly leveraging intravascular ultrasound to facilitate this.
How does intravascular ultrasound specifically help in this acute setting where the anatomy is often just completely occluded and distorted by clot?
Oh, it changes the game, especially for trainees learning the approach. In acute PVT, the ability to use intravascular ultrasound to assess the exact extent and consistency of the thrombus load before you even place the TIPS is invaluable. And more importantly, it helps guide your needle access through that dense occluded portal vein. It allows us to confirm access into a patent lumen. It further provides real-time feedback that fluoroscopy alone simply can't offer. The Advancing Liver Therapeutic Approaches Consortium advice reinforces this structured approach. Low-caliber TIPS is generally recommended for non-cirrhotic PVT only after anticoagulation has failed following that initial thrombolysis or thrombectomy.
Speaking of access, let's pivot to the technical hurdles of just getting to the clot. Recanalizing a completely occluded portal vein is a high-level skill set.
Complete occlusion drastically increases the technical challenge for the standard retrograde recanalization. When we can't get in retrograde, we often have to resort to antegrade approaches, transplenic and transmesenteric access, which were traditionally reserved for chronic cases but are increasingly deployed acutely when immediate outflow is just necessary.
And that transplenic access has really shifted practice, hasn't it? It demonstrates excellent success rates. I think Habib et al. Showed 100% technical success for PVR TIPS in non-cirrhotic patients. But for us, the critical safety data is that studies comparing transplenic versus transhepatic access have found no significant difference in major complications. And that's despite the fact that we're traversing the spleen. That confidence in transplenic access is a game changer.
Conversely, while transhepatic access is common, it requires careful consideration, particularly in patients who might have ascites or an underlying coagulopathy, which are common in these sick patients. Furthermore, the necessary sheath size limitations in that approach can sometimes increase the bleeding risk right through the liver capsule itself.
And what about the historical transmesenteric approach? The one that used to require a mini laparotomy and was associated with a higher risk of adverse events. That's evolving as well, isn't it? I've seen recent case series demonstrating feasibility using ultrasound-guided percutaneous access, suggesting that this avenue is becoming less invasive and maybe a more viable backup option.
Innovation in access just means fewer absolute contraindications to intervention.
Okay, let's discuss a scenario where the medical management is dramatically different, forcing us to integrate these interventional skills with complex systemic pharmacology. I'm talking about acute PVT in the setting of COVID-19 and VITT.
Yes, these contemporary pathologies are really challenging because the PVT is secondary to a systemic hypercoagulable state. In COVID-19, the virus induces a massive hyperinflammation. We've seen venous thromboembolic complications in up to 59% of ICU patients, and that confers a hazard ratio of 2.4 for mortality.
Yeah.
The clot is it's more aggressive.
And the timing is key. PVT onset is often rapid, typically within 2 weeks of diagnosis, averaging around 12.3 days. The debate here seems to center entirely on optimal anticoagulation dosing in a hospital setting, prophylactic versus therapeutic. Some centers favor therapeutic unfractionated heparin, right? Primarily due to its short half-life and reversibility, especially compared to low molecular weight heparin in patients with fluctuating renal function. We're also seeing recommendations for extended prophylaxis up to 45 days to account for that delayed onset PVT.
And then you have vaccine-induced immune thrombotic, thrombocytopenia, VITT, or pathology to understand because of the severe implications for treatment.
Right. It's a rare complication, about 3 per 100,000 vaccinations. But clinically, it's frightening. It mimics heparin-induced thrombocytopenia involving high titers of antiplatelet factor IV antibodies. It typically occurs 5 to 42 days post-vaccination.
And this is the absolute crux of VITT management. Because the mechanism is similar to heparin-induced thrombocytopenia, the use of heparin must be strictly avoided. You are directly feeding the pathological process. Management requires a true multidisciplinary hematology consult focused on non-heparin anticoagulants, direct thrombin inhibitors, or direct oral 10A inhibitors, along with immunotherapy like IVIG and steroids to modulate the immune response.
So for the IR specialist, this is a major caveat. You do not intervene until the correct medical regimen is established. You have to confirm your anticoagulation strategy is non-heparin-based. Interventional measures, whether IR or surgical, are strictly reserved for failure of this targeted medical management.
Knowing the pathology must precede treating the clot. And this flows directly into the most critical decision point we face, differentiating reversible ischemia from irreversible infarct.
The proposed treatment algorithm, which is often adapted from the Bovin 07 consensus, absolutely pivots on this distinction. Is the bowel still potentially salvageable with rapid endovascular revascularization, or is it already irreversibly necrotic, demanding immediate surgical resection?
And thankfully, our ability to predict irreversible necrosis is improving. For the IR consultant reviewing the case, multivariate analysis has identified 3 powerful measurable factors. 1, organ failure, defined by a Marshall score of 2 or greater. 2, serum lactate levels exceeding 2 millimoles per liter. And 3, bowel loop dilation, clearly visible on CT imaging.
And the clinical urgency associated with these factors is stark. The risk of irreversible injury is only 3% if none of those factors are present, but that risk jumps to 38% with just 1 factor, 89% with 2, and it reaches 100% when all 3 are present. These numbers force us to move immediately toward a surgical consult if the patient hits 2 or 3.
Exactly. And while lactate alone isn't conclusive evidence of necrosis, it can occur in reversible ischemia. Its combination with other CT findings, like pneumatosis intestinalis or free fluid, as quantified by models like the Emil-Kahn score. That combination collectively guides that urgent decision. This is the moment where IR truly interfaces with surgery and critical care, defining the necessary acuity based on evidence, not just clinical suspicion.
So what does this all mean for us moving forward? Well, anticoagulation remains standard initial care. Interventional management through PVT tips and the use of large-bore thrombectomy offers crucial, often life-saving treatment when medical management fails or when there are escalating signs of ischemia. And we now have proven alternative access approaches, notably the transplantic route, and a much better understanding of how to manage complex systemic etiologies like VITT without causing harm.
The final provocative thought for you to explore is portosinusoidal vascular disease, or PSVD. This is an underrecognized underlying etiology of portal hypertension, and it's responsible for PVT in up to 30% to 40% of non-cirrhotic patients. Now, while the treatment for acute complications remains similar to other causes of portal hypertension, the long-term prognosis for PSVD is generally considered much more favorable. For the trainee, considering PSVD in the differential means ensuring the workup is complete, as confirming that diagnosis dramatically impacts patient counseling and long-term surveillance planning, even if your acute intervention remains the same.
That's it. Thanks for listening.
This is Dr. Rusty Hoffman, and that's a wrap for Wisdom Radio. Download the Wisdom app by searching for Medical Wisdom, spelled WYSDOM, or visit medicalwisdom.ai for rapid-fire videos, podcasts, and community insights. And remember, knowledge is the best medicine.